of IAP Kerala. Okay, welcome you, sir. Then I welcome all the postgraduate students or junior residents who are attending this program. I think this is quite useful for all of them because they have an contact with all the faculty across the state and even from outside. And I request Joseph to give his introductory remarks. Over to Joseph. Joseph, unmute ചെയ്യണേ. Joseph, unmute ചെയ്യണേ.
Audible, is it audible? It's audible?
Audible, sir. Audible and visible. Okay.
Thank you, Dr. Suresh, IAP Kottayam, taken all the initiative to organize the program. Respected faculty today, Dr. Purushottam sir, HOD ICH, Dr. Dali madam, the convener of the program, Dr. Shanavas sir, and all the senior members of the IAP and all the postgraduate students, Dr. Ashadi, who is going to present the case today. As we are conducting regularly the meeting every Thursday 7:30 p.m. And I think very much the PGs are very useful for this program with different faculty to discuss the different cases in a different way. I think this program is very useful for all of you. And I wish you all the best program. Jai Hind, Jai IAP. Over to Dr. Suresh for further proceedings.
Suresh, unmute you.
Shanavas sir. Over to Shanavas sir.
Okay, very good evening to our respected IAP State President Jose sir, Purushottam sir, and HOD Kottayam, Darli madam, Suresh sir, and all other faculties. I'm very happy to be with you all for this PG clinical case presentation from Kottayam IAP, where it is always in advance they are selecting cases and selecting the faculty very regularly, and that is a very good attendance in these times. And today's the chair is also an expert clinician and a good teacher of all of us, and most favorite teacher in almost in all case presentations. So I express all the best. Thank you very much.
Thank you, Shanavas sir, for your kind words. Now I request Darli madam for the introductory remarks.
Respected Dr. Jose, State IAP President, Purushottam sir, Shanavas sir, Leda madam is there, all the faculty members who have joined the program, and also all the junior residents. I wish all success for this particular program, because I am the mentor. I don't have much to say. I wish happy learning for everyone who has joined. Thank you.
Thank you, madam. I take this opportunity to welcome our professor and HOD, previous HOD, Lata madam, to this program. And I wish all the best for Ashwati. And I request Purushottam sir to take over the session.
With your permission, and my teacher, Lata madam, senior colleague, Dr. Sudhakaran, will start after a gap. See Sudhakaran. So, Ashwati, you can share the screen.
Okay, sir.
Read out the history part slowly, and then come back. Complete the history part slowly so that people can follow. There's no need to hurry. Slowly. Okay.
Okay, sir.
Full screen.
Sorry, is it visible?
Visible.
Okay.
You can start.
Thanks. Good evening, everyone. Today I am going to present the case of a 9-year-old boy from Pathanamthitta. Date of admission on 24/8/2023. Date of examination on 27/8/2023. Informant is mother. History is reliable. Presenting complaints. Child was admitted with complaints of headache of 1 week duration,
weakness of left upper limb and lower limb of 1 day duration, urinary retention of 1 day duration, and deviation of angle of mouth to right side of 1 day duration. Coming to the history of present illness. 9-year-old boy was apparently normal 1 week back when he developed headache, which was acute onset, severe throbbing type, bilaterally over forehead, 2 to 3 episodes per day, each episode lasting for about 1 to 2 hours. It subsides with paracetamol. First attack of headache was associated with vomiting, which was projectile, non-bilious, contained food particles. Headache was so severe that he was unable to do his daily activities, and he preferred to sleep most of the time after the onset of illness. He was initially shown at a local hospital and was given paracetamol, and was BP was checked there and was said to be normal. Ophthalmology consultation was sought and was found to be normal. As headache persisted, he was shown at our OPD, wherein CT brain was advised, which was normal. There was no history of any diurnal variation of headache, no history of blurring of vision, photophobia, or phonophobia. On the 8th day after onset of headache, he developed weakness of the left lower limb, which was gradual in onset in the form of inability to wear his chappals along with difficulty in walking. Weakness was associated with inability to void urine. He went to a local hospital and was treated with some oral medications along with IV fluids and was discharged after observation. By the next day morning, over a period of 24 hours, weakness progressed to such an extent that he was unable to lift his left lower limb and left upper limb, or turn side to side or sit up by himself. He was also not able to hold glass or even move his fingers of the left hand. Eventually, his weakness extended to right lower limb over a period of 12 hours to such an extent that he could only move his right toes, further impairing his mobility. No history of any easy fatigability or diurnal variation for the weakness. As urinary retention persisted, he was catheterized from a local hospital and was referred to our center. Mother also noticed deviation of angle of mouth towards right side, along with drooling of saliva from left side, but he was able to close his eyes at that time. He was appreciating touch and pain. No history of any numbness or tingling sensation. No history of any slurring of speech, altered sensorium, seizures, or loss of consciousness. No history of any excessive sweating, salivation, or lacrimation. No history of any trauma, recent vaccination, or drug intake. There was no bite marks. No history of any loose tooths. No history of any altered smell, abnormal deviation of eyes. No history of any abnormal sensation or face or difficulty in chewing. No history of any nasal regurgitation, nasal twang, or difficulty in swallowing. No history of hoarseness of voice, hearing disturbances, vertigo, or tinnitus. There was no history of drooping of eyelids, blurring of vision, or any involuntary movements. No history of any fever or nuchal pain. No history of contact with TB. No history of dyspnea on exertion, palpitation, or cyanosis. No history of any skin rashes, oral ulcers, or joint pain. Child was admitted in our hospital and was treated with IV medication followed by oral drugs, with which child improved over a period of 1 week to such an extent that he was able to walk by himself. Urinary symptoms recovered by a period of 1 week. Coming to the past history, no history of similar illness in the past. History of AURA 2 weeks back, which was managed symptomatically. No history of any previous hospitalization, recent vaccination, or any vaccine preventable diseases. Coming to antenatal history, he is the first child of non-consanguineous marriage, spontaneous conception 1 year after marriage at a maternal age of 30 years. Regular antenatal checkups were done at GH Pathanamthitta. First trimester, pregnancy detected after 4 weeks of amenorrhea. No history of hyperemesis, fever with rash, spotting TB, or urinary tract infection. No history of any drug intake or radiation exposure. 2 doses of TT and folic acid tablets were taken. Second trimester, quickening was felt at 5th month of gestation. No history of any gestational diabetes, gestational hypertension, or bleeding TB. Iron and calcium tablets were taken. Anomaly scan was normal. Third trimester, no history of any gestational diabetes, gestational hypertension, no history of any bleeding per vaginum or leaking per vaginum. No history of any decreased fetal movements. Natal history, he was born term by emergency LSCS, indication being fetal distress. He cried soon after birth. Birth weight was 2.8 kg and he was born at GH Pathanamthitta. He was breastfed within an hour of birth. He was feeding well, passed urine and meconium within 24 hours. Postnatal history, no history of any neonatal jaundice, neonatal seizures, or NICU admissions. Development history, his development is normal for age, currently studying in 3rd standard with average scholastic performance. Dietary history, he was exclusively breastfed up to 6 months. Complementary feeding was started at 6 months with Ragi, started family pot sharing by 1 year. History of increased appetite and weight gain over the past 2 years is present. His diet is mainly based on rice, fried snacks, juices, and shakes. Diet is deficient in fruits and vegetables. This is the diet. He is getting a calories of about 2,730 against an expected of 1,690 according to ICMR. There's a calorie excess of 1,040 calories. He's getting a protein of 90 grams against an expected of 29.5 grams. He's getting an excess of 60.5 grams of protein. Immunization history is immunized for age as per national immunization schedule. BCG scar is present. No history of any adverse event following immunization. No optional vaccines were taken. Family history. No history of similar illness in the family. History of cerebrovascular accident in the maternal grandfather at 65 years of age. Comorbid conditions associated with dyslipidemia and hypertension. No history of young stroke or early deaths in family. This is the pedigree chart. Coming to socioeconomic status, mother studied up to 10th standard, currently working at Haritha Karma Sena. Father studied up to 10th standard, he's a manual laborer. They live in a Pakka house, good sanitation, well water for drinking. Belong to lower middle class family as per modified Swami scheme. Sir.
Okay, we'll go back to the first slide. Okay. So this is a 9-year-old child with a headache 1 week and 1 day of all these complaints. Left-sided weakness. Later, right, according to right lower limb, there's a facial deviation. There was no altered sensorium according to you. So, you're seeing the patient on the 3rd day or 5th day?
5th day, sir, after admission, on 6th day of illness.
5th day of illness means the 5th day of weakness, not from the headache.
From the weakness, sir.
5th day of the weakness. Okay. So initial day, previously normal child, headache started. Okay. And headache was the only problem in the first 7 days, according to you.
Yes.
Okay. And you go to the description of the headache. Next slide. Okay. What was the headache like?
The severe.
Headache. 2 to 3 episodes per day. And details are not enough here. Because previously normal child and significant headache is there. And first episode, you said there was vomiting. And there was no mention of the vomiting after that. Headache, 3 episodes per day. And was that the same throughout that 7 days headache only? All the other events happened on the 8th day. There is a need for elaboration of that headache. So what are the importance of that headache in that context? Because this case, it's very difficult. The difficulty and the thing is anatomic localization of the problem. In any case like this, you need to answer sequentially. Is there a neurological problem? If so, where is or where are lesions? And third, pathological basis of the anatomical localization. That's a sequence in which you are going. So out of this, from the history, the pathological base is a bit easier. And the most difficult thing in this case is to answer anatomical localization. Okay. The points which are you depend on, hard findings, each of them need to be taken. Out of which headache is one. Okay. So in a context of a weakness like this, headache, what are the conditions which you consider? And what all details you need to ask about the headache, which is incomplete here. What all ways the headache is relevant?
Sir, based on the timing of headache, whether it is early morning or during daytime also it persists. Likewise, we can rule out migraine or.
Of course, one of the possibilities is migraine sometimes can lead to few of the neurological problems. Okay. For that, you need history. Is the history of the fever, if the headache in this episode suggestive of migraine, and in the past history, according to you, in the history, there is no past history, there is no family history of in the family history, you didn't mention about the headache, you didn't ask about the families in the pedigree chart. So when you construct each of these things, it's not enough to say, ask, is there any other similar history in the family? This is one thing which has got you will get the point, argue for or against from 2 areas, from the past history and from the family history. In this case, is there any point? There are the criteria for defining a migraine in a child. So out of which family history is very strong. In this case, is it suggestive of a migraine?
No, sir. It is not unilateral, and there is no photophobia or phonophobia associated. Then there is no aura.
There is not many points. The same headache was there during the first week together daily. And the features of the headache are definitely not fitting with the migraine. Okay. And more important, what are the points? What is the other reason for headache?
Any vascular headache.
That is migraine, almost migraine. What is in this context? What is the reason for it you are postulating?
Sir, I didn't get, sir.
Headache. In this context, what is the mechanism of headache you are postulating? Gopinath and Anshad can also answer to this question. Don't leave Ashwati alone. What Anshad? Anshadinte kuttine maati vechittu parayu. Anshad.
Sir, it could be either due to raised ICT,
Very
or
good.
it could.
So that is the most important. So is this suggestive of a raised ICT? What are the points which you need to bring in?
Usually in raised ICT, the headache will be very severe and will be associated to multiple episodes of projectile vomiting, and usually more in the early morning hours.
That need not always be, because that early morning headache for a chronic raised ICT situation like ICSOL and all. Raised ICT, as you said, severe headache, projectile vomiting, and what else? What are the other points? Raised ICT headache? Any altered sensorium, right? Okay. Any other thing? What are the any pain when you are talking? There is systematically what is the intensity, what is the type, and what is the other thing about any pain? Headache also.
Or aggravating factors.
Aggravating factors and relieving factors. Is there anything typical? Raised ICT?
There won't be any aggravating factors.
What is the aggravating factor typically? Which will aggravate, which will indicate aggravating. What are the features which will aggravate a raised ICT headache? Anshad, Gopi?
Early morning hours itself due to increased circadian rhythm of CSF.
No, that's not the thing. What activity will increase, precipitate, worsen, raise headache if it is due to raised ICT? That's the point.
Bending.
It's right. Bending forward, sneezing or coughing. All these things increases the. So that is one point. These are the points which you need to come, because headache is can be due to migraine in this context, but this point is not is it due to raised ICT? That should be mentioned here. Was there any aggravation during these procedures which will suggest that raised ICT? On what way in this context, raised ICT in the context, how that will be important in the where is it? Localization helps. It's helpful for the pathology also. So if there is a significant headache which is likely to be raised ICT, in this case, the features are not. If so, in what context? In an acute short duration problem, pathology helpful.
Hemorrhage or anything.
Right. If it is a vascular problem leading on to this sort of a neurological deficit, there are two situations. Okay. One is there is a bleeding. The other is either emboli, thrombosis. So the differentiation from these two scenarios is raised ICT. So raised ICT, which are the situations in which in vascular problem, the raised ICT is likely, or headache like this is likely? Is it hemorrhage only?
Hemorrhage, sir. Hemorrhage.
90% of these are arguing that for a hemorrhage, but if there is an ischemia also, sometimes it's massive, large vessel occlusion, sometimes there can be raised ICT. Okay. So that is one point, very important, headache. Okay. In what other way the presence or absence of the headache is relevant? It's mainly for the pathological analysis. Okay. Headache, yes or no. In this case, raised ICT headache is there, argues against or for what are the pathologies?
Any intracranial tumors?
Intracranial tumor. In this case, the overall picture is not suggestive of the duration of only 1 week. So less likely for intracranial tumor. If at all, say tumor with a bleed or something should be happening for this thing. Less likely. Okay. What other way? What is the other possibility? Arguing for or against in this case? Headache, if you think it's a raised ICT. Other pathologies, okay. One is vascular. There is no trauma you mentioned.
Yes, sir. No trauma. No history of any trauma.
Other group of disorders which are presenting like this. Demyelinations. Okay. So what is the chance of a race ICT in a demyelination?
50%.
What is Anshad? What's your impression? Anshad, Gopi Mundinilla Gopi lived. Gopi na adele Peru Gopi Pinera.
Mamta, sir.
Mamta, Renduveruilla. Mamta undalla. Chance of race ICT in a demyelinating disorder.
Least less likely.
Not common.
Less likely.
Not common. Less likely. Okay. Even though there are criteria for central demyelination, there is mention of altered sensorium. Okay. Altered sensorium. But that headache is not a must, because race ICT is not the reason for the altered sensorium in that demyelination. Anyway, the details of the headache you need to go in depth, because it was the only symptom in this 9-year-old boy for the initial 1 week together. And the features were not suggestive of the race ICT. There was only one episode in the first, there was vomiting. And throughout, there was no other features of race ICT. So this point is relevant when we discuss the pathological basis. Okay. Then the whole duration, if you draw the picture of the headache, that's important. When you approach a headache, the nature of the headache over time, how it behaved. In this case, there are 2-3 episodes per day. And over days, how it worsened or diminished. You said it is responding to paracetamol. Was it totally asymptomatic in between? Okay, active and playful. A little more of description of this 1 week is important in this case. So 1 week is there, then only the other neurological problems happened. So there is a chance that this headache may be unrelated. So don't jump to the conclusion that this headache is part of this thing. So there again, you didn't mention about the other reason for the headache. 9-year-old child all on a sudden coming with a headache. And according to you, there is no fever. So if there was fever, we need to consider infections, CNS. Okay. For 1 week without fever, so that goes down in the list. That also is an important DD, apart from the vascular trauma, all these things, infections also. So fever is absent here. But in this context, what are the other associated things which you need to mention as a negative point? 1 week of headache. Sinus problem. Okay. And other reasons for the headache also need to be mentioned as a negative point. Okay. So now it is going to the 8th day of the onset of the illness. Go to the next slide. Previous slide, anything more? Headache. 8th day of the onset of the headache. It developed weakness of the left lower limb, which was gradual in the onset in the form of inability to wear chapels, along with the difficulty in walking. Weakness was associated with inability to wear. So on the day of the evolution, there is a lack of clarity. What are the when you describe the history part in the neurological analysis, it should be breaking up into the functional component. Each of the functional component need to go in depth. One is, what about the motor component? What about the sensory? What about the spatial senses? Cerebella? Then about all these components need to be analyzed. Sensory part, abnormal movement is the, so all these things. Out of which, in this case, the highlighted thing is most important, the weakness. Okay. Of the lower limb, you said the upper limb also. So how it evolved? Is it a suddenly in the upper and lower limb together. It progressed initially lower than the upper. What is the time span between this evolution? Was it distal, proximal, or was the evolution? So these are all important when you analyze the problem, because there are different ways in which it can occur. The time in which it evolved from the 0 to this point, evolution. And what is the pattern of this thing? Weakness, maximum at the beginning, gradually improving. Weakness progressing gradually over time and evolving to the maximum in that duration. And the other way, the territory involved. Leg followed by the upper limb. Upper limb and face and no leg. So distribution all important. Again, distal or proximal. So all these things are important. In here, you just mentioned that was gradual. That sort of it became severe enough in the no time. That sort of journalist description is not the one thing which you need here. Very specific things are important. So these questions need to be answered. So what is the importance of this evolution? From what you describe, what is it suggestive of? Again, that is suggestive, helpful for the pathological. Of course, a little bit of anatomical localization is helpful because it is one side only, left side only is one. It's a focal event in the neurological. It's not a diffuse event anyway. So focal event, that's what you can say. It's one side of the limb on the day one, and there is a facial involvement. So what way these are arguing for your diagnosis? In this case, why I am going in depth about this thing is, don't be biased. We are not interested about the diagnosis and the investigation. How when a patient comes with a complaint, you analyze. That is what. Okay. So weakness of the motor, how you go forward, and what is the pathological? The time part. Okay. So from the minimal to the maximum, it happened within 24 hours. So what does it argue? It's a very helpful, very important thing for the pathological. Okay.
Thrombotic, maybe a thrombotic type of vascular event.
If it is a vascular, what you said is right. So most of the vascular, what are the events which will produce suddenly?
Hemorrhage.
No. What are the neurological events when you're getting a neurological lesion, which will present suddenly within a matter of minutes, maybe hours? Sudden evolution in neurological problem, what will you consider? Either vascular or traumatic. Okay. In this case, there is no trauma. Okay. So forget about the trauma. So next comes the vascular. Okay. So if at all it is a vascular, what does it argue for? Do you think that will you consider vascular in this case, or can you rule out the vascular pathology totally against? That's my question.
Sir, at present we can go in for a vascular event initially, because it involved left side. It presented as a left-sided hemiplegia initially, along with headache, which progressed over. Initially, it was distal weakness, which progressed to involve left proximal.
So what does that argue for?
Vascular event.
If at all, vascular, which vascular event will be behaving like this, if at all? My question is, can you rule out vascular? No, you said it can be vascular. Okay, I agree. Is there a clue that which type of vascular? Which vascular will behave like this?
Progressed over a time, and from minimal to maximum, it can be a thrombotic event.
Right. For the vascular event which can present like this is thrombosis. So what way the hemorrhage and the embolic stroke will behave? on the day one, if it was left-sided thing, upper and lower limb are involved. Okay. What way? If it is an embolic or a hemorrhagic will behave.
Sir, embolus will within a seconds it can.
Embolus, the worst weakness at the onset within seconds to minutes. Then over time, it will be only an improvement. There are different mechanisms. Okay. So you are bringing here the headache. So you are taking the headache as part of this thing. So what does that argue for? Hemorrhagic. So do you think this is a vascular phenomenon with a hemorrhage likely here?
Possible.
Possible. Okay. How can you explain the 1 week headache, the 2 episodic, and all of a sudden happening? Can it happen? Can a hemorrhagic problem occur like that?
Usually acute hemorrhage will be acute.
Need not be. There can be a small oozing, gradually producing, and the weakness. The hemorrhage need not always be in any of the motor pathways. So initially, it can lead to raised ICT features, and once it evolved, there can be this sort of an evolution possible. But in this case, a bit unlikely, because from that point onwards, you are not mentioning about the headache after that.
Sir, not audible, sir.
I'm audible? I'm not audible.
You are audible, sir. No problem.
Now you are audible, sir.
No audible. Okay. So if it was a bleeding, the headache will not disappear on the day and the time of the weakness. It will persist because the problem of the raised ICT part will be persisting more, and there's no altered sensor. So there is a possibility of a vascular event. If at all you are considering, that must be thrombosis only. So which area anatomic localization thrombosis you will go for?
Sir, middle cerebral artery.
Don't go to the pathology of this thing. Which localization, which area, when you talk about that, which area in the neuroaxis will lead to this phenomenon on day one? When you're getting a weakness of the lower followed by upper, as I said, okay, let it be lower and upper.
Sir,
Then the same day you said there was deviation of face to the opposite side. So the same side, weakness, same side of the face and
UMN.
okay. So, right. Where is the pathology?
Cortex.
Cortex. Mamata, what you said? What you say?
Internal capsule.
Internal capsule. What are the point arguing for the possibility anatomic localization in the internal capsule, and why I'm not agreeing with cortical?
Internal capsule usually present. Internal capsule stroke usually present with as a dense hemiplegia.
So, what is the definition of dense hemiplegia then? Is it the density, severity is grade 0 power? Dense hemiplegia means what?
Upper limb, lower limb.
Upper limb and lower limb are
Lower limb activity.
same grade of weakness. Same grade of weakness, usually severe grades. So there is no, it's a degree of the weakness. Okay, both are involved. So what is the point against it being a cortical, if it is so?
There is no altered sensorium.
Right? Then
Or LOC.
Seizure.
Seizure.
there is no seizure. And what more? One more?
Vision or
What is the other thing which is very, very important, which will argue for a cortical involvement? Speech.
Appreciation.
Speech. There is, according to you, there is no involvement about speech. So cortical is unlikely. There is no altered sensorium. There is no speech involvement. Okay. So in this case, where exactly internal? Okay. When will you? What is the facial palsy like?
UMN type of facial palsy.
UMN. How that help you? In this case, you think it's a dense hemiplegia, same level of power loss is there in the upper and lower limb. According to you, more weakness in the lower and upper was not that much. And it evolved in a sequence. Internal capsule, will it be in a sequence? So point for and against in this case. Internal capsule, is it likely, more likely or not?
Yes.
Will it be like that? The lower limb followed by the upper limb?
At same time, the weakness will be.
Usually it's the involved vascular situation, usually the small area. So unlike even if it is a thrombus, if it is this location, it won't be taking that much time. 24-hour gap will not be there. So it will be involving simultaneously both upper and lower limbs. Not this gap will be there. And the power part will be almost equal. So point a little bit against. So in this context of a UMN facial palsy, where is the lesion? But when will you narrow down the lesion? Where is the facial?
Above the level of.
Above the level of the lower pons. It can be mid pons, medulla, internal capsule. Okay. And cortical definitely no. Subcortical again is a bit unusual. Okay. About the speech part. Okay. And that is important. And what happened next day and next day? On the day itself, there were two things which we need to go in depth again. On the day one itself, you said facial palsy. On the day one itself, you said there was a problem with the voiding of urine. So these are areas where you will find it very difficult to localize. That is the problem here. Okay. So why I'm coming to that? You need to, on the day itself, there was a voiding problem on the day itself, on the day one itself. Okay. So where do you think the problem in this case about the voiding? That is one thing, very, very important.
Cortex.
What will be the problem of the voiding if it is in that paracentral lobule? Mamata can answer. Mamata is answering? Okay.
Urgent continence.
Urgent continence. What about Anshad? You're postulating the lesion above pons.
Yes,
Can be anywhere. And you're having a urinary problem. Okay.
Incontinence is more common.
So what will be the urinary disturbance in this context? Anshad, Mamata, Gopi?
Sir, usually in cortex lesions, we expect incontinence.
No. Ria has answered. It's nothing. The reflex will be normal. Nothing will be there except social inhibition. Social inhibition. So that's not a common entity in a pediatric age group. That's a problem of the geriatrics. Still, there can be some of the situations can occur. 9-year-old child, nobody will give any value to this social inhibition. They'll take it as normal. That's why this entity may be existing, but we may be missing. Prefrontal lobe tumors and all that can be this thing, but we may not be considering because 9-year-old child, they'll take it as normal. Social inhibition only, the reflex will be entirely normal. That is the catch in this case. On the day one itself, what was the bladder disturbance? You described that. You didn't go in depth about that bladder part. So what are the point which you need in when a child comes with, when a person comes with a voiding disturbance? What points are needed? What are the usual reasons? Mamata. It's not enough to say that there's a voiding disturbance. You need to go in depth. What are the, what you keep in mind?
Any pain associated?
Very good, very good. So there are two ways in which urinary disturbance can occur. One is urological, other is neurological. Okay. So what are the points which will argue that it can be urological? Because there is no rule that there can be a coincidence in UTI or some other thing. There need not be fever in all cases of UTI. There can be urinary disturbance only. Okay. and sometimes even worm trouble, another foreign body, not many other things for a urinary disturbance, okay, in a child. So any pain is so important. In this case, there was no pain. You didn't ask about that.
Pain was there, sir. Lower abdominal pain was there.
Okay. Pain argues for urological or a neurological?
Argues for a neurology.
Urological. Pain on maturation is not a pointer for a neurological bladder. Okay. Okay. But what are the other things, other points in the history?
With the constipation.
What all points will you ask which will help in the evaluation of the neurological bladder? What are the neurological bladder? What all ways it can present? What are the controls? One control is now just we describe, that is the paracentral lobule up to the pontine area. In this case, it is not. There is an actual voiding disturbance here. So you cannot explain this by any lesion in that part. So it must be a lesion somewhere from the pons down. And what are the pons down? Neurological entities which will have a voiding disturbance, and which questions will answer?
Early bladder involvement along with weakness.
No, your answer is different. Mamata, which are the urological disturbance? What are the bladder patho problems?
Bladder. Spinal cord.
Okay, Mamata, answer. UMN bladder, LMN bladder, the classical ones. You get the bladder disturbance in a UMN, bladder disturbance in a LMN, and there is another situation, the sensations not felt. So which all questions are needed here before going in depth about this? So which all questions will you ask in this case? Anshar, a 9-year-old child, you can ask which questions? Whether you can perceive the bladder sensation, that is one. Second thing, when you feel that urinating, can you initiate urination? Third thing, whether you can complete the voiding. And the last thing, is it dry in between? So this question should be there in evaluation. And in the examination, you need to assess the other parts of the bladder, palpation, anal, bulbocavernous, cerebrus, a lot of other examination findings. This point should be coming in the history. Okay, that will only tell you is a UMN or an LMN about the in-between dry or in-between wet and episodically going. Okay, sensation loss. You cannot initiate. So all these history points need to be there when you're talking about the bladder disturbance. It's not enough because in this case, with the present possibility, you cannot explain the bladder problem. That is, there you will find it difficult. Okay. Okay. Then comes your facial weakness, also which occurred on the same day. Okay. What are the history points which you need to ask in that situation? You said only deviation of the angle to the opposite side. Okay, opposite side. So what are the other history points which you need to ask?
Whether he was able to close the eyes.
Right. In this case, he was able to close eyes.
Yes.
Okay. There was a deviation. Okay. And what about the other things which you need to ask a little bit more? Functional problems which will be created by the facial weakness. That also, what all functional problems? Speech. What are the problems in the speech?
For taste sensation.
that is a different thing. That is what will be involved in this case. You think taste sensation will be involved in this entity?
When you blowing the face, blowing the
Right. So Ansha, you're silent. Ansha is the. What are the functional problems in a case of facial palsy which you need to ask in the history?
Drooling while feeding.
Right. Drooling and the accumulation of food particles in the. It's not actually drooling. It's just going out of the mouth. Drooling. These are two entities. Drooling is a problem of difficulty in swallowing and drooling. Here it is again. Drooling is there, but it's from during the chewing only. The other thing is swallowing problem. Drooling always will be there. Here during the chewing only it comes out. Okay, that is one thing. And what is other disability? In the speech, what will be the effect in the speech? Is it in the speech? What is affected in the speech? Some words only. Articulation. Okay, it's a vague term in the articulation. Some words. Which words will be affected? Facial. Articulation. Words. What are the words you ask about? Labial.
Labial.
Okay. Papa, baba, ma. Tata, dada, na. Sa, sha, sha, sa, ha. Okay. Out of which all these things are linguals. Papa, baba, ma. Okay. Kaka, ga, ga, nga. Kaka, ga, ga, nga is palatal. Tata, dada, na. Sa, sha, sha, sa, ha. Sta, ta. Okay. All are linguals. And here, so there is a problem with the speech, no problem with the comprehension, no problem with the expression, only articulation, and the articulation is labial. So you can ask about, is there any change in the words in this form? Then you can examine also. And is there a problem with the feeding in this manner? So that is helpful. And one more thing, the next day, he had a weakness on the other side. That is the very, very complex thing, how to explain. There, if you think it's a bilateral problem, what will happen to the facial? That is something which is very difficult to explain in this case. You're getting a problem the next day on the other side. Okay, other side. So, what will happen? What you're expecting for the facial? That's a very interesting thing. When there is a deviation, that's easy. Okay, it's one-sided, other side power is normal. Okay, so then only deviation. What will happen if there is a problem of the facial weakness on the other side also?
bilateral.
It will behave like, it will become bilateral facial. So what will be your impression? What way that will cheat you?
Emotional.
You feel that the patient is recovering because the pull on the other side will not be there. It will gradually disappear. Okay, so what change will happen there? If there is a weakness on the other side, the pull part will be gone. And what will disappear then? It will be a bilateral element or UMN, both will be the same. So the deviation part will disappear, but what will happen? Bilateral eye closure, forehead wrinkling, everything will be going. So in this case, very interesting, when you're getting something on the right side also, which you need to consider this part also at this stage. That didn't happen here. Facial palsy persisted. Okay, you go ahead, go forward. Okay, on the day IV fluid, then next day morning over a 24-hour period, lower limb, upper limb, side. There in the second stanza, second sentence in the paragraph, there's a problem here. Next day morning, over a period of 24 hours, weakness progressed to such an extent that. So that is not the way you are presenting. It's not a journalist language. The severity increased to such an extent that he was unable to lift his left lower limb. Not the way. what you need, what we are interested is the weakness. Is it a severity increase only, or is it distal weakness, proximal weakness? All these things are needed. So how to differentiate the weakness? Distal, the use of chapels. Proximal, sitting and standing from sitting position. So those things are needed. It's the severity throughout diminished, or proximal distal variation was there. And the next thing, he was not able to turn side and sit up himself. All these things are important when you're assessing the functional thing. So weakness is in the limb only. Is there in the trunk weakness? Is there in the neck weakness? So when you're assessing the weakness, topography of the weakness, the pattern of the weakness, both are important. This is all helpful in the topography of the weakness. The truncal weakness is there or not. He's not able to sit up from the lying position. The way he is holding the neck. So those are important, not just like the severity, weakness progress to such an extent that that's not the way. So that is helpful not to assess the severity, but the topography of the involvement. There is a truncal weakness also. So that is important because the next day you had the right-sided event also. Otherwise, in a case of hemiplegia, left-sided thing only, the truncal weakness is unlikely. He was having difficulty turnover and sitting. So by that time, the weakness occurred on the right lower limb also. Okay. And the next point, you said he was not able to hold a glass, or even that is very important, because when you are talking more about the weakness, you need to talk about this thing, use of the hands for all these purposes. Then use the proximal thing. Also able to lift above thing for combing, for brushing. So all these things are important. These are a weakness of the periphery only. These are a weakness of the truncal. So those things are needed in the history. Go to the second slide. Next slide. Yeah, this again, eventually his weakness extended the right lower limb in a period of 12 hours to such an extent that he could only move his right toes, further impairing his. This is all journalist language. See, this is not the one which we need here. Eventually, the weakness increase is not the thing. The weakness, he started to have the weakness on the right lower limb within the next 12 hours. Okay. And that was severe weakness. So that is a totally difficult problem. So when a patient is having already this pattern of hemiplegia type of pattern of weakness, where you are postulating a lesion above the pons, here is a situation where you are getting the right lower limb weakness. So how to explain that, and what are the ways in which you can explain when such a context occurs? Mamata? Manmada Anshad? Where will you postulate the lesion and how? Was there a weakness upper and lower limb on the right side, or lower limb only? Upper limb, according to you, upper limb is paid. That's one from the history I made.
Yes, sir.
Right upper limb weakness was there?
No, sir.
Right lower limb weakness was there according to you. It was less compared to the left side. Right upper limb, according to you, there was no weakness. Okay. So where will you postulate this particular? So there cannot be an encroaching from left to right like that. The first paragraph you said, eventually his weakness extended to some neurological term, it's difficult to explain. There is no way it can encroach. If you apply the neuroanatomy, that's a bit difficult. That's why. What is the explanation? It cannot encroach like that. What is the explanation? Where will you postulate the anatomical localization?
The disseminated lesion like that.
It cannot be explained by one lesion. That's a point. That is one very important. With one lesion, you cannot explain. There must be more than one lesion. And now comes, where is the second or more than one lesion? you are likely postulating. For this weakness, in this history stage, you said it's in the right lower limb only. It's a lesser grade of weakness. So where will you postulate, Anshad?
Left side.
Left side where? Left inside in the brain in the internal capsule or the same brain parenchyma matter.
It evolved over a period of time, so probably cortex.
Again, cortex. We have already argued against the cortex. Now, what are the points for the cortex? Cortex.
Progression is a bit gradual, and multiple infarct is there. So,
who told you infarct, or why you are going for the pathology? Just talk about the anatomical. Don't go into the pathology. I'm not talking about the pathology. Where is the question? What is not the question? Where in the neuroaxis can explain this? On the next degree, right lower limb weakness. Is it possible for a similar suprapontine lesion to explain this thing? And in that case, what is the problem? So there can be a possibility of a lesion anywhere from the pons to the internal capsula, wherever subcortical. Is it happening on the other side? And is that a good explanation? Is it possible? Or where will you postulate the lesion?
Most probably subcortical, suprapontine.
Suprapontine. In that situation, what do you expect? The very same manner, the other side of the okay, in that situation, suprapontine means in the suprapontine, where in the previous stage also, suprapontine where? In the medulla, in the pons, in the midbrain. Is it likely?
no, sir.
Oh.
Brain and all child will be more sick, and
It's not the sickness. It's not the sick. What is the point arguing against it being a midbrain or a pons?
3, 4, 6 cranial nerves are not in.
Very good. In the brainstem, the hallmark of the brainstem involvement is multiple cranial nerve involvement. Okay. In this case, there is no cranial nerve involvement. There is no altered sensorium also, can be there. Multiple tracts there. Okay. And multiple cranial nerves. So it cannot be in that part. Okay. It must be above. Okay. Somewhere above this thing. Can't say where exactly. It is in the subcortical up to internal capsule up to this thing. Definitely not in the pons or this thing. If in this area, on the other side also it's happening, you're postulating. Can that explain this thing? Will you find it difficult? I'm not asking what is the pathology. Again, you are going to the pathology. If there is any anatomical lesion on the other side, let it be demyelination, let it be infarct, let it be another thing. Can it explain?
Other side facial nerve is normal.
Right. Very, very important thing. If that was the situation, the facial nerve, why one side facial nerve on the other side facial is spared? Is it possible? Something which is responsible on the other side, responsible for the lower limb weakness, there will be involvement of the upper limb and the facial also. In that situation, facial will be behaving in the manner which I told you. Bilateral facial weakness will be there. In this case, it's a unilateral facial. And according to you, upper limb is spared. So that cannot explain. Then what will be the other anatomical occlusion you go for? And again, can it explain the bladder disturbance? Mamada. This bladder disturbance cannot be accounted by this area lesion. So what is the most likely thing?
Maybe extensive lesion.
There is a
lesion.
There is a lesion in the spinal cord, most likely. Okay, then only you can explain, because the bladder problems in the this particular location which you are mentioning is very, very unlikely to be explained by that lesion. It will not occur. Bladder problem, if it be occurring, it must be in the medulla down to the spinal cord up to the S23 or S23. Okay. So in the pontine and the above cannot produce this sort of a bladder lesion. And this mono, according to you, it's a lower limb only. Now, in that context, also, you need to explain by another lesion in the spinal cord. Okay, go ahead. Previous slide, once more. The noise to PC fatigability or diurnal variation of the weakness. This diurnal variation all are important when you are considering the lower motor unit disorder. In this case, when you are approaching a weakness part, is it fitting with a motor unit disorder or a central? Here, what are the points with the almost argues more for a central? There are not many. There was a initial headache part, there was a UMN facial palsy. So definitely there is a central. You are not considering lower motor, but there's a possibility of an coexisting thing, UMN plus LMN, that will come only when you are examined. Okay. So in that situation, only the diurnal variation. Okay. And urinary retention persisted. Like, go to the next slide. Towards the right side, along with the rolling of saliva, he was appreciating. Then the other functional things, he was appreciating touch and pain. Okay. And what more is needed when you're describing about the sensory part? This is another functional component. What are the sensory problems? He was appreciating touch, pain, temperature also. He's appreciating the dress. Okay. So what additional thing about the sensory part is needed? Subjective? Negative and positive. He may be appreciating pain. Which lesion will produce a pain? Pain?
Neuropathy.
Pain in this context. Don't go wild. Once you are there in this thing, don't bring 1, 2, 3, 4 like answering. Which localization in this area will patient will be having pain? Anshad, Mamata?
Very usually subjective symptoms.
No. If the localization, especially stroke situation, there can be pain. Which it's not loss of pain, I mean, it's pain appreciation. It's a thalamic. Thalamic, if there is a thalamic involvement, there can be pain. So when you're mentioning about the pain, that also. Okay, go to the next slide. Okay. For speech part, again, a little bit more in this speech part is needed. In any hemiplegia-like situation, you need to go in depth about the speech part. You was comprehending what you're talking? Comprehending, and he was doing what you were asking. Okay. Okay. Then expressing content of the words. Normal content was there. Okay. Amplitude of the sound was normal. Yes, sir. And the speech expression, and you need to consider the recovering of the aphasia. So aphasia or dysarthria, if it is the aphasia, again, there are few more things which you need to go in depth. You need to ask him to repeat about the fluency, the number of words, and ask him to make him to write and read. In an ideal child, is possible. Okay, so those things are needed when you're talking about the hemiplegia with facial palsy, because that is very closely related anatomically thing. You're talking about the cortical, subcortical and all. So unless you are going in depth about the speech analysis, it's incomplete, especially when it's a recovering situation or partial involvement, subcortical and all. Okay, subcortical and all, there can be a little bit subtle involvement of maybe the repetition only, maybe the with the naming or some part of the speeches maybe involved. The speech analysis should be complete. Okay. The other thing, when you mention about the history, the history should be divided a little bit, which will be helping for the neuro localization, which will be helping for the pathological analysis. Don't mix these things. So trauma, recent vaccination, drug intake, bite mark, all these things are arguing for a pathological analysis. Okay, so you take that to the end. So points which are helpful for the neurological localization are coming again. Okay, go to the next slide. So this is the sequence thing which you are arguing for. There is no first nerve, there is no second nerve, there is no, that is what you're coming here. So in this situation, so which are the cranial nerve which you need to go in a little more in depth? That's a vision part. In this vision part, you'll need a little more of a vision part is needed. Why?
So, sir, to differentiate between cortical.
Vision, I mean.
Okay. Internal capsule lesion can present visual defects.
Internal capsular lesion, cortical.
The internal
Okay, before that,
any
we are discussing about the pathological conditions. Okay, some of these pathological conditions where with this visual analysis will be helpful. Demyelination, if you are considering demyelination, this visual analysis become more important. Okay, the acuity, feel, all those things are very important. The analysis, and you can ask about the visual problem, whether there is a constitution of the field, whether you can see the sites, all these things in the history part. History part of the visual analysis that is needed. Okay, the lower cranial nerve, nothing is there. No nasal regurgitation, nasal tongue, all day. Okay, pause in the voice. Go to the go forward. Okay. Okay, there is no involuntary movement. What way does involuntary movement is important?
the extrapyramidal lesions can present with abnormal involuntary movements.
Involvement of the extrapyramidal, whatever pathological situation, there are few pathological situations which are helpful where involuntary movement, altered sensorium will be more common that way. In this case, there is nothing. Okay, go forward. Now, child improved over days. You have seen the patient on the day of treatment started?
Day 3, sir.
Day 3 of the treatment. So patient was recovering. That's why many features. You go to the examination. Go to the examination. And the rest of the history, there is nothing. Okay. And in here, two things. In the some family history, a little bit inadequacy is there, because in the family history, you need to go in depth about the other disorders where stroke run in families. There is no rule that this is demyelination, because you said there is 2 weeks back there was fever. Demyelination is possible, but some of the vascular events also can be the family history of this stroke-like situations, neurocutaneous conditions, and migraine. Very important, the family history. In the dietary history, what are the dietary things which are needed? Apart from the contents, you said higher intake is a calorie protein, but there can be some of the deficiencies in the micronutrients which can have a bearing on the stroke situations. Okay, and very, very important, it's not only that, what way the feeding is affected. Okay, because the feeding will be affected in different situations. Facial, there will be some loading. Okay, in the 9-10 is involved, it's a pseudobulbar palsy situation. Okay, so how the feeding is affected? Go to the examination, general examination. Read the examination totally.
The child was conscious, oriented in time, place, person.
Okay.
Attitude of the child.
Read. Go forward. Read.
Attitude of the child. Child was lying supine on the bed with hands by side, shoulders adducted, extended at elbow, bilateral lower limb abducted and externally rotated. Vital signs, pulse rate 86 per minute, regular in rhythm, volume and character, no radiofemoral delay, peripheral pulses were palpable, BP equally, BP 100 bar 70 millimeter of mercury recorded from right upper limb in supine position, respiratory rate 26 per minute, saturation 98% in room air, temperature was normal, 98. Coming to head to foot examination, head appears normal in size and shape, hair normal, there was acanthosis nigricans, no neurocutaneous markers, eyes, ears, nose, oral cavity normal, chest and abdomen appears normal, normal male external genitalia, bladder was catheterized, IV cannula present on the dorsum of left hand, SMR stage 1. Coming to anthropometry, his weight was 51 kg, expected is 28 kg, that is about 97 percentile. Height is 144 centimeter, expected is 135 centimeter, that is between 90th and 98th centile. Coming to head circumference, it is 52 centimeter. Body mass index is 24.6 kilogram per meter square. Expected is 16, 27 adult equivalent risk for obesity. Waist ratio was 0.93, this less than 0.9, increased health risk. Development assessment, he is able to do simple arithmetic calculation like addition and subtraction, reads out sentences, throws cylinder.
This point is very important. Previous slide. So previous slide, when you talk without thinking, read out sentences and draw cylinder. Did you test the reading out sentences?
Yes, sir.
When you talk about this is stated for the developmental assessment, you should be very careful because a child having some sort of an aphasia, there can be a problem with the reading. That's important. And draw cylinder in a patient who is having weakness of the upper limb. So there should not be contradiction when you state all these things. Without thinking will be in an examination also. Without thinking will be here stating like this. At the end, you will not be able to substantiate this thing. Okay, good. Go forward.
Higher mental function, child is conscious oriented with normal memory and intelligence. Right-handed, normal speech, mother tongue is Malayalam.
Wait here, the previous slide. Okay. This is very important in this analysis here. The patient never had an altered sensorium, and when you saw the patient also, consciousness was maintained. It's an intelligent child. Speech was normal. Full component of the speech was normal. Okay. Was there any problem with the labials, Papa, Baba?
No, sir. He was
recovering.
Recovering phase.
Okay.
Cranial nerve examination, olfactory nerve not tested, optic nerve, visual acuity normal.
In this case, you didn't test many of these nerves. Olfactory nerve, there is no problem in testing in a 9-year-old child. You can test it. Go. Okay. In this case, it may not be that much needed. Should be trying to test this thing. If you are in the examination, in a child who is conscious 9 years, I didn't do this thing, it's not an excuse because child is not sick. 9-year understanding. Okay.
Color vision normal, fundus normal bilaterally, no evidence of
field of vision. Is it important in this case?
Yes, sir. Yes.
Optic nerve is very important in this case. Everything. The field, vision, fundus, all these things are so important in a case like this. And you can make this child sit in this patient. Child was walking, you said. On the day your examined child was able to walk.
He was bedridden.
Bedridden. Was he able to sit?
No, sir. He was not able.
Okay. Then the field of vision may not be possible. Okay. Fundus.
Fundus was normal, sir. No evidence of any papilledema.
Okay.
3, 4, 6 cranial nerves examination. No ptosis, spin, nystagmus or diplopia. Sorry. Extraocular movements were full in all directions. Pupil size and shape normal and equal bilateral.
What else will you ask when when you are asking for looking for the extraocular movement? When you look for the extraocular movement, of course, you'll be looking for the full movement. You will looking for the nystagmus. Okay. One more thing which is relevant in this case is there any pain? Okay. What is it important? Why is it important?
Optic nerve, neuritis or
Optic nerve, papillitis. You heard of papillitis, you got optic neuritis, and so one of these point is pain on the movement. Okay. There is no ptosis. Okay. Pupil, you need to mention in the second nerve also. Okay.
Okay.
It's equal, normal size and reacting.
Yes, sir.
Okay.
Cranial nerve examination of direct light reflex present bilaterally, indirect light reflex present bilaterally, accommodation.
So what is the question which is likely to come in the pupillary reflex analysis here? Mamta, very interesting point about the pupillary reflex in this case.
RAPD.
Right.
Relative of some people reading.
Okay. So, okay. That is likely in the case of if you're suspecting demyelination, very important. One side only involved. Okay. Then, right. Go ahead.
Trigeminal nerve, motor part, opening of jaw, there was no deviation. Temporalis and masseter were normal.
You are testing the crane of fifth. Okay. What all things you need to test? You need to palpate. Okay.
Palpate on cheek.
Deviation, if you are expecting motor involvement, one side only. So what about chewing? Chewing is possible.
No.
So how will you assess the deviation of the jaw in the context of the facial palsy? There is a facial palsy. There is a facial palsy. And you want to assess the jaw deviation. Will it be easy? There is already a facial palsy. Will it be easy in that context to assess the unilateral jaw deviation due to trigeminal motor? What will the difficulty? How will you circumvent that?
Sir, we can differentiate.
Anshad, where will you look for jaw deviation? The teeth. Okay. Should not be concentrating anywhere on the soft tissue. The teeth. Okay. So what is happening to the incisor teeth and the gap? In the facial palsy, the lips will be deviating and you should be concentrating on that. If there is a deviation of the mandible, it won't be. It will be deviating. So that is the point. Okay.
Sensory part.
Sensory part, you didn't test. Why didn't you test him?
Sir, I tested. Touch and pain was appreciated.
Okay. Over the face. Touch and pain for appreciated. So what way the sensory testing of the fifth will you be doing? Which is not relevant in this case, but it may be relevant when you are evaluating the brainstem area, whether it is in the midbrain, pons or medulla. If there is a motor involvement of the trigeminal, if there is a sensory involvement of trigeminal, what is the localizing value?
Pons.
Motor involvement will occur
Pons.
only in pontile. Okay, what about the sensory?
Sensory thalamus.
Sensory involvement, Anshad? Is there is a half facial sensory loss? Okay. This side sensory loss indicates pontine lesion always. Anshad, anganeyano?
No, sir. Any local lesions within the mastoid and all can also.
Forget about that part. That's a totally different thing you're answering. Anatomical localization in the brainstem when there is a half sensory loss. Does that argue it's a pontine lesion always?
No.
It can be anywhere. There can be a sensory loss up to the C5 cervical medulla and in the midbrain also. Okay. So sensory loss can be in anywhere from the midbrain down to the C5. Motor means it is in the pons. Okay. In what else? What way the sensory testing should be done? This is my question. It's not enough to touch here and here. Is that enough? Where all will you touch?
Over the maxillary mandibular and
Or the maxillary, mandibular, and this thing. If there is a disparity between these 1, 2, 3 areas, what does that argue? This is loss and this is present. What does that argue? It is not within the parenchyma. It's gone out. It's in the divisions. Okay. So it's not a parenchymal lesion. Okay. So what other way you should be testing? You should be testing between here and here. Here and here. Okay. So what is the importance of that? Sensation to be tested for light age test and temperature and pain. That is one thing. Sensation to be tested in the 3 divisions. That is second thing. The third thing is sensation to be tested between medial to lateral. What way that is important? And that is how you differentiate whether the lesion is in the midbrain, pons, or in the medulla bar upper spinal cord. So that is how this arrangement. So sensory part. Okay, go ahead. Go forward. Georgia absent, corner reflex present, conjunctival reflex present. Is there a catch here? Is there a very important point here? Ansha, this is a very strong point here in your analysis. What is it? Georgia present. How that is important here? Such an important point here in this case.
aggravated, we can, in case of bilateral involvement.
In this case, what are you postulating? What were you postulating?
It's not a pseudo, but
When there is a bilateral neurological problem, we were postulating a possibility of a suprapontine lesion, pons up to the subcortical, anywhere. Definitely, it's not a pons or midbrain, at somewhere above. Okay. So if it is bilateral, which could have been you are postulating for accounting the limb, Georgia will be exaggerated. Georgia need not be exaggerated in the unilateral. Georgia will be exaggerated in the bilateral situation. And one more thing, go forward. Okay, facial now.
printing our forehead is present bilaterally. Eye closure can fully close against resistance. Angle of mouth, there was no deviation when I saw. Nasolabial fold was less prominent on left side. Sensory part, I think that's face over anterior 2/3.
Don't say in the examination, I didn't test because it's a 9-year-old child and in the lying position, fully conscious, aware child, you can test. So, don't take this an excuse not testing because this should be tested. Because in this case, it's not needed. It's not needed in this case. So, I didn't test. That's a good argument because I'm not suspecting an element facial. So, I didn't test. So, if you are getting an element, it should be testing. Here, it is not needed. Okay, right. Go to the
Examination of 9 and 10 crenula. There was no nasal regurgitation or position of uvula was central. Palatal movements were bilaterally equal. Sensation over posterior 1/3 of the tongue not tested as it's not significant here. Then reflex, gag reflex is present.
Gag reflex is present. Is that important now? With the same discussion. Okay. Gag reflex present. Is it present only? Or is it exaggerated?
Pseudobulbar.
In this case, that is again, jaw jerk and this jerk are very, very important. If you are postulating a lesion bilaterally, this jerk also will be exaggerated and you will get a swallowing difficulty and drooling. So that is not there in this case. It's a very, very important for the anatomical localization. Go forward. Shanavas, 20 minutes on to finish here. Shanavas in the
Okay, sir. No problem.
Okay, sir. Okay, sir. Okay, sir.
I'm not concentrating on
Okay.
management part only. Okay.
Vestibulocochlear nerve examination. There is no nystagmus, tinnitus, or vertigo. Renine and Weber
So
test.
in the history part, I forgot to mention, when you're analyzing the history, all these things should be coming. The hearing part, vertigo part, because in the stroke analysis, one of the DDs is definitely stroke. In the stroke analysis, motor weakness, the sensory part, spatial senses, the valence part, this tinnitus, vertigo, all these things should be coming in the history, which will be giving a point for your analysis and localization. Okay.
Spinal accessory nerve, shrugging of shoulder could not be assessed. Movement against of the neck against resistance was present bilaterally. Hypoglossal nerve, there was no deviation of tongue on.
So in the brain stem, all the cranial nerves except the facial are intact. In the facial also, it's a human.
Yes.
Okay. Actually, there is no true involvement of the nuclei of any of the brainstem nuclei. That's what your final answer. Okay. Oh.
Motor system
Now
examination.
we are interested about the long tracks, motor and sensory, and the maybe in the other things also. One of these things you mentioned, corners, it is not there. Pupillary size is normal. Okay. The other sensory and the bladder is there. So we are interested about this thing.
Bulk, motor system examination, bulk, there is no wasting.
You don't expect any change in the bulk. Short duration.
Tone, bilateral upper limb and lower limb, I found hypotonia was present.
Is that enough here? Anshad, is that enough here? Upper limb hypotonia present bilaterally. Is that enough? The tone need to be compared bilaterally. In this case, it's unlikely because you said upper limb was not weak. How can be bilateral hypotonia? Okay. And you said the lower limb left side was very weak, the other was. So there cannot be hypotonia is there in both sides, but there is a difference in the sides. That also is very important. And tone is not in the limbs totally. Okay. There can be patchy. The proximal distal difference is there. So it's not enough to say that. Okay.
Coming to power. Shoulders, right side, shoulder, elbow, and wrist, rate 4/5, and left side, shoulders.
So in short, the power is more affected on the left, but there is a weakness in the right also. From this point onwards, you are changing your previous position. There is an involvement of the right upper limb also. There is some weakness. That's what you're postulating, or is it a normal thing?
Yes, sir.
There's a weakness of the right upper limb also.
Yes, sir. Yes. On examination.
Not to that extent. Okay.
Yes, sir.
There is some weakness in the upper limb, more weakness in the left upper limb. Okay. And there is one more thing. There is a distal proximal variation is not there.
No, sir.
So, but why should you ask for the distal proximal variation? Which one?
Motor unit, motor differentiate between involvement of.
Is it in this case differentiation of your motor unit from the muscle with that is not the situation here. Here you are not talking at all about the motor unit. Here when you are talking about the human type of weakness. So there, where will you get a distal weakness? Proximal spare. Where will you get the proximal weakness? Distal spare. So these are all important in the stroke analysis. Upper limb and facial more involved, lower limb not involved. Lower limb more involved. And these are all very important in the stroke analysis of which vessel. Okay, there again, this is important, distal proximal. So how is it important? In this case, you said everything is equal. Okay. Is it helping you in your diagnosis, or you're putting into trouble? If it is if you are going to postulate this stroke, you will be a little bit in difficulty, because in the stroke situation, usually there will be a disparity between the distal proximal. It's a uniform. That is one thing here. Okay, go ahead.
Coming to lower limbs, hips, hip, right side hip, knee.
Here again, there's a clear thing. Left side, 0 power in the distal and proximal. In the right side, there is some power, but there is a significant power loss. So there is clear-cut one more thing. The upper limb, lower limb disparity is there. So it's not only the lower limb. The worst power is there in the lower limb. Upper limb, there is almost good power in the right, a little weakness in the. So there is a major difference also between these limbs. So how that is helpful? How that is important in this case for the anatomic localization? There is a difference between the right and left side in the lower limb. There is a definite difference between the upper and lower limbs. There is a difference between the upper limbs. Okay. So how can you, but what way that is important?
If you send one.
If it was a lesion intracranial anywhere, okay, intracranial anywhere, but how it will be behaving?
Based on vascular.
Forget about the pathology part, anatomical.
If it was in the.
So there cannot be that much of a difference. Apart from the, of course, as you said, vascular lay. There can be lower, if it is a vascular lower limb, what will be your localization?
ACA territory.
ACA territory, bilateral, unpaired, this thing can produce paraplegia like a situation, but in that situation, it could be occurring, should be occurring simultaneously. And upper limb, there cannot be a variation between the two sides. There cannot be this much of weakness in the upper limb. So that cannot explain. Okay. So that is again another thing. There must be another lesion in the spinal cord. Then only you can explain these differences. Okay. Okay, go ahead.
Reflexes, deep tendon reflexor, Georgia.
See here again, jaw jerk is absent here. Okay. Jaw jerk is not exaggerated. Okay. All the other risks are brisk. There is human bilaterally above C4. Okay. Anywhere. But brainstem part is spared. Okay. So you are postulating either bilateral in the higher level. That cannot explain the bladder. So there must be lesions, additional lesions in the spinal cord. Okay. In the cervical segment also. Okay. Okay. Go ahead.
Going to the superficial reflexes, corneal, present right and left side. Conjunctival reflexes present bilaterally. Abdominal reflex present. Plantar on right side it was mute. Left side it was extensor type. There was no involuntary movement. Gait could not be assessed. Cerebellar signs, finger nose test was normal on right side. Diadochokinesia was also normal on right side.
Little one point here again. Examiner may not agree. In this case, could you elicit the diadochokinesia normal on the right side? Will you be able to do when there's a power of 3 on the left side, power of 4 on the right side? Will the baby on the left side hand can raise like this for this thing? Less likely. When the power is affected in the bilateral, especially grade 3 power only is in the left side. Sometimes it may be difficult, most of the situations. Okay. Finger nose test also, grade 4 power is needed. On the right side, you said. Right. Okay, that side. Okay.
Sensory system, pain touch was normal bilaterally, upper limb and lower limb. Then joint sense and fine touch was also normal.
This is
My
important here because you're very likely that there can be a sensory loss in this case because there is a bladder involvement also. With this involvement, you are explaining there is a possibility of spinal cord additional lesion. These all this sensory in depth is very, very important. Okay, go ahead.
cortical sensation, tactile localization was normal, bilateral upper limb and lower limb. Stereognosis was normally present. No signs of any meningeal irritation. Peripheral nerve system, there was no nerve thickening or tenderness. Skull and spine was normal. Examination of other system.
All the other systems are normal. Okay, go to the diagnosis.
Acute demyelination, probably.
What's the problem with your final diagnosis here?
There can be involvement of both involvement of spinal cord as well as brain.
In this case, first you need to say where or is or are the lesions. Anatomical localization followed by the pathological. Okay. You are not interested whether it's a demyelination or whatever. So where? That's a question. That's a question need to be answered. So there must be definitely on the right-sided lesion which account for the left-sided hemiplegia part. Agreed. Okay. And there must be additional spinal cord lesions also. Then only you can explain. Okay. At least in the cervical part. Okay. And the bladder must be in the UMN bladder. Cervical part, likely, but that one lesion again cannot be explained because there is a disparity between the upper and lower limb. So more than one lesions must be there in the spinal cord also. We need that investigation also. Go ahead.
The investigation.
What are the positive findings in the investigation? Just tell.
Total count was elevated 18,650.
Okay.
Then his lipid profile.
Was there any other associated infection to account for this thing? You don't consider an infection in this case so far. Must be some other additional infections like respiratory or some other thing to account for this thing. There was no fever also. Okay, go to the other.
CSF study was done, which showed a lymphocytic predominant. TC was 67 with the lymphocyte predominant, that is 95%.
So is that important? This finding is important?
Yes, sir.
Because we are considering pathological basis. What are the pathological basis you are considering? Anatomical and pathological basis. I am sorry. In the diagnosis, where is the lesion and what is the pathological basis? What is the pathological basis you consider? Demyelination. So it cannot be explained by a vascular because it's not respecting any vascular territory. So must be possibilities in that situation. Multicentric localization. One possibility is demyelination. Other possibilities which can occur in multiple sites. Less likely in this case. Vasculitis. There can be secondary or primary vasculitis. In the description, there is nothing secondary, nothing in the systems. So primary CNS vasculitis can also present with multiple focal infections. So vasculitis is unlikely. Demyelination goes high in the list. So in this situation, this LP is supporting that. Okay. There is cells, presence of cell, argue for edema and lymphocyte predominant. What's the importance of lymphocyte or polymorph predominant? Is that important? Just because there is a polymorph predominant, there will be considering infection and putting on antibiotics or some other way it is important.
So we may go in favor of infection only.
Even when you are having a documented supporting a demyelination, it can be another different types of demyelinations are there which are not prognostically good. So this pattern also is important. Okay, go ahead.
MRI findings, there was a
so the MRI and tell the findings. Where are the findings?
A patchy hyperintense lesions on the
when you are describing an MRI, again you need to tell many things. Which is the MRI?
Sir, it is
Is
a
that what? Okay, what type of, what is the
T2-weighted MRI showing patchy infiltrates over frontoparietal region as well as gangliocapsular region.
region side? It's
Axial.
it's axial cut. Axial cut in a sequence, starting from the top, going down. It's the right hand side. It is above. It's in the lateral ventricle. They are showing. All the left three are above, starting from this thing. And there is in the first itself. There is on the left side. You are getting a lesion here. It's a, you describe that. It's a hyperintense, uniform, linear. Okay, that is the lesion seen here. And when you go to the third one, there is another 2 lesions on the right side also. So right side means as if you are looking from the foot end. Okay, that's why it's the right side. There are 2 lesions seen. Okay, and in the last at the ventricular level, there is a lesion on the right side again. It's a go to the other films, other things. Okay, this is
The flare image.
flare images. Okay, which a flare?
T2.
T1 flare or T2 flare?
T2 flare.
T2 flare. Okay, T2 flare images. What are you seeing? So you read that top. The lower cut is from the top. You are going gradually down, and in the upper cut again, you are reaching the ventricular top, lateral ventricle, going down to the thalamic caudate, and the last part is at the level of the thalamus caudate. Okay, what are the findings seen here? As you go down in the fourth, okay, as you have marked, there is a lesion on the right side. Okay, and here in the left extreme, there are the lesions bilaterally. Okay. Okay, then you go down. Is there any lesion in the internal capsule evident here?
Yes, sir.
Not much, not much. In the thalamus? Not much. Okay. The other area? Okay, go to the other films. Previous? This one only you have taken. Okay. So your diagnosis of Adam is right. And you have done the MR angiogram, and here again in the MR, very important, you need to check the optic nerve also in the sagittal cuts. Okay, optic nerve and optic asthma are important in the evaluation. Okay, go to the last slide. So final diagnosis.
Acute. This is a case of acute demyelination.
Okay. So you're not going much in the theory. How did you treat with?
We treat with methyl prednisolone, 30 mg per kg for about
You
5
got a good response. Okay, what are your plans? Just tell me the plans and what can happen. Outcome.
There can be recurrence.
So you're putting the patient on oral steroids?
Oral steroids or a period of
How long?
6 to
4 to 6 weeks. And what is the outcome likely in this case?
outcome. There can be, we need to closely monitor the child. There can be a chance of recurrence in case of antibody related. If antibody related, there can be multi-phasic ADAM can present. That is another episode of ADAM demyelination can present within or after a period of 3 months. So we should closely monitor the child, and we should also check his eye evaluations. Then we
Right. Don't go into. There are a lot of other varieties of complications can be there. Other types can be there. Okay, follow up also. Shanavas, I'm stopping here. Thank you, Ashwati and Anshad, Mamda, Devo, Gobi didn't join. Okay, thank you. Good presentation. Shanavas.
Okay, thank you very much. Very wonderful discussion. So the history discussion, nobody will be discussing such a way. Purushottam has done.
Actually, can I stop the screen sharing? Shano sir, please continue.
It was a very wonderful discussion. So all the aspects are discussed in detail. So many points for those who are attended from neurological point, general point, or everything. So thank you very much, sir, for your presentation.
I couldn't complete. There was a lot, many things about the other things, sir. With this short time, one day, all these things, sir, you need to read, Ashwati. All the postgraduates need to
So
read.
we will not get this much things from when we read, sir. Only when from your mouth we are hearing it. So we have read so many things, but we are not getting so much points.
Thank you, Shanava, sir.
So Suresh, sir.
Shano sir rightly stated, you won't get this much many points once to read it. Even if you read all basis, you won't get such kind of localization and discussion. Every time when you're saying discussing only, you will get through that, sir. It was very wonderful discussion going on, sir. Darling madam. Darling madam.
Thank you, sir. Just a wonderful, exhaustive discussion, I should say. Almost all the points were in the history, everything was told. And this boy is now walking. He came for review, I think 1 week back, he came walking,
Good.
doing good. And antibodies came as negative also. It's done at demands and it's negative.
Okay. Emerging number of spectrum disorders, so we did that.
Yeah.
Okay.
Actually, he was so fortunate that everything recovered over a period of one time and effectively went with that medial prednisolone.
Good response.
Thank you, sir. Thank you, Ashwati, for that presentation. And thanks to all who have attended. Shanava, sir, for being attending this program through the entire sessions. Darling madam, thank you for attending this session.